welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today in this episode, we shall look at the hemogram and how to interpret the hemogram. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Hit the like button, drop a comment in the section below to show some support, share the page to someone who you think may benefit from this channel. Grab your piece of paper, grab your pen, and let's go. Today we're going to be focusing mainly on the hemogram, or what I love to call the medical students' national anthem. The reason why I refer to it as this is because when you ask students for what one investigation would you order for, over 50% of medical students usually go for an full blood count or a complete blood count, or they say hemogram. So remember that the hemogram can also be referred to as a full blood count or FBC, which is what we shall be using to refer to it in the rest of this lecture. It can also be referred to as a complete blood count. And remember that this is actually one of the most frequently ordered hematological tests and hematological investigation that we can use in the diagnosis and management of various clinical conditions. It's going to have various parameters that can range from about 13 parameters to actually 19 parameters. And mostly it's going to be looking at the cellular components of blood. Remember that blood is a connective tissue that's present in the body in fluid form. It's going to be consisting of formed elements, which are pretty much red blood cells that have a role in tissue perfusion as they functioning in carrying oxygen and carbon dioxide to and from the tissue. Then white blood cells, which have a major role in their host immunity, both the cell-mediated as well as the humoral immunity, as well as platelets that have a very important role in inflammation, as well as they have an important role in hemostasis and coagulation. So some common indications that you may need to know that may warrant you to do an FBC include some suspected clinical disorders such as anemias, thrombocytopenia, infections, leukemias, bleeding disorders, cancers, allergies, immunodeficiency, hemoglobinopathy. We can do the full blood count pre-operatively. We can also do it post-operatively. We can do it before a transfusion. We can also do it after a transfusion. We can also use the full blood count as a supportive management of certain conditions when we want to monitor the progression of the treatment. We want to monitor if there is any adverse side effects that may be present, for example, with certain drugs. But that list that I just gave you is not an exhaustive list. Those are just some of the common indications for an FBC. There are actually more indications that we actually use an FBC in. Even in obstetrics and gynecology, we may use an FBC to actually, as part of maternal care, as part of antenatal care. Then remember that blood is going to be made up of cellular components, so pretty much red blood cells, white blood cells, platelets that are going to be found in plasma. And this plasma is going to be accounting for 55%, while as the white blood cells about 4%, and the red blood cells about 40 to 45%. And remember that the white blood cells could further be divided into neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So what you really need to note is that the cause of many abnormalities may actually be obvious when you do your full blood count. But if you find any unexpected findings on the full blood count, for example, if you're expecting to find that the level of HB should be low and then you find out that it's extremely high, then this warrants an explanation. This warrants further investigation of the patient. And not only will the FBC going to help you in achieving a prompt diagnosis in many patients, but awareness of common causes of each individual abnormalities might as well prevent unnecessary investigations. Because if you know that microcytic anemia, which is caused by iron deficiency, will present you with a low MCV, you get a low MCHC, you also get a low HB and a low red blood cell count. Your next step would obviously be to order for maybe studies that are going to be showing you the cause of iron deficiency. So you wouldn't be investigating this patient, for example, for vitamin B12 deficiency, or you wouldn't be investigating them for folate deficiency. So it helps us narrow our investigations and helps us think of the next possible step that we can actually order. And remember, sometimes you may get unexpected results such as a low platelet and an HB, and often you should perform some technical validation verification of the result by, for example, checking the integrity of the sample. You may also ensure that the sample is not clotted, because all these things can affect the level of the platelets. It can affect the level of the HB. And all the results that you get from your full blood count must be correlated to what you have on your history. It must be correlated to what you have on your physical exam. So if someone has a very low HB and clinically they seem to be okay, they are not pale, and they do not have any features of anemia, it could be that maybe there was a mistake when collecting the sample, or there was a mistake when actually analyzing the sample. So you could draw another sample to confirm, and you obviously going to be marrying your FBC results to your clinical findings. Remember, we deal with patients. We do not deal with results. You don't treat the results, you treat the patient. Then how exactly do we carry out a full blood count in FBC? So we're usually going to be drawing blood from a vein in the arm or the back of the hand, and we're going to be placing this in a purple bottle. And this purple bottle has an anticoagulant, which is ethylene diamine tetraacetic acid, or EDTA for short. Some common side effects, though are very rare, of a vena puncture and drawing blood may include things like lightheadedness, bleeding, and infections, especially if it is recurrent and you are removing large amounts of blood. So remember that the FBC and the parameters can actually be determined manually, and you can actually determine the red blood cell count, you can determine the white blood cell count, you can determine the platelet, you can determine the HB, the PCV, and the differential leukocyte count. While as the other indices such as the MCV, MCH, and MCHC are going to be calculated using your HB, your PCV, and your red blood cell values, while the absolute values are calculated using the percentages of the differential count over the total white blood cell count. I will tell you what all these definitions mean very shortly. So if you are still lost and have no idea what MCV, MCHC, RBC, WBC mean, I will allude or point towards this later on. So you can also use an automated machine, an automated hematology analyzer that can actually that is actually present in many laboratories and countries, including in our setting. So the parameters that are going to be measured on the full blood count include the following things. You may sometimes not have all these parameters. Sometimes you may have some of them that are not really measured. Like, for example, the differential count sometimes may not be included. Sometimes it may be included. But generally, you have your white blood cell count, which is abbreviated WBC, the red blood cell count, which is abbreviated RBC, the hematocrit, which is abbreviated HCT. Sometimes this may be referred to as the packed cell volume, or PCV, the hemoglobin, which is abbreviated HB or HGB. I shall call it HB. Then the mean corpuscular volume as MCV, mean corpuscular hemoglobin as MCH, mean corpuscular hemoglobin concentration as MCHC, red cell distribution width as RDW, the differentials in percentages as well as absolute values of the neutrophils, lymphocytes, monocytes, eosinophils, and basophils, the reticulocyte count in percentages and absolute values. Sometimes this may not be there on your typical FBC that you see on the wards, your platelet count, your platelet distribution width, which is abbreviated a PDW, the mean platelet volume, MPV, and the platelet large cell ratio, which is the PLCR, as well as the immature granulocytes, which is IG. So before we go into the details of each of these parameters, what you really need to note is that there are some variations based on gender. So before puberty, in prepubertal humans, there's actually no major differences between the RBC count and the hemoglobin. So females and males have roughly the same amount of hemoglobin, the same amount of red blood cells. The only variation is due to age. So you get someone who's maybe an infant having a much higher HB than someone who's maybe a child that's aged 6 years old. That's already for obvious reasons, because when a child is born, they have a very high HB because they have been in the uterus, which is a relatively hypoxic environment. And remember that hypoxia stimulates the release of erythropoietin, and erythropoietin stimulates the red blood cell synthesis. So the newborn babies may actually have a relatively high HB. They may have a relatively high RBC, but of course this is going to decrease progressively as they get much older. And then the gender differences actually creep in when the menstruation actually happens. Remember that males, aside from cutting themselves and bleeding from wherever they may be bleeding, there is no physiological way in which males can actually lose blood, or physiological way in which iron can actually be lost in the male. But in females, most of this is lost during menstruation, which is the cyclical bleeding that happens from the uterus each and every single month. So these gender differences actually revert back to normal 10 years after menopause, when the HB becomes quite similar to that of the same aged male. Then adult men as well as adult females have going to be having different HB. They're going to be having different RBC levels. They're going to be having different hematocrits or PCV in health status. Then the gender differences is going to be independent of iron status. Remember that iron replete premenopausal women have mean HB that is approximately 12% lower than the age and the race of the same counterparts, the same men. Then this gender difference in mean venous hemoglobin levels as well as RBC mass is generally going to be considered to be caused by this direct effect that you have on androgen in men, because remember there is a high concentration of androgens in men, and this high concentration of androgens in men in association with a hormone that's known as erythropoietin, which is produced from the kidneys, stimulates the bone marrow to synthesize these red blood cells. But enough about this physiology. Let's now go into the different parameters of the red blood cells so that you get into the gist, and you should be able to know how to interpret the hemoglobin levels, how to interpret the RBC and other parameters. And in essence, when this lecture is done, you should be able to interpret the hemogram. So if you are satisfied and you are able to interpret the hemogram after this lecture, please drop a like and also drop a comment. Comment the word done below to show that some support that indeed you are understanding these lectures. So we'll start with the WBC count. Remember that white blood cells are going to be fundamental to both the humoral as well as the cell-mediated immunity. Humoral to do with antibodies. Remember that there are different types of antibodies: IgG, IgA, IgM, IgE, and IgD, which are predominantly synthesized by B lymphocytes, which differentiate into plasma cells. Then you also have the cell-mediated immunity, which are pretty much dealing with cells and different processes, including phagocytosis, just to mention a few of them. Then these white blood cells are going to be helping in fighting infections, and their normal ranges can actually variate between different labs, and they can variate between different countries. But in general, for men, you have between 5,000 to 10,000 cells per microliter of blood. Then in women, you have 4,500 to 11,000 cells per microliter of blood. In children, you have 5,000 to 10,000 cells per microliter of blood. So in general, we can use the threshold of 4,000 to 11,000 microliters per blood, microliters of blood. Then if someone has white blood cell that is exceeding 11,000, you refer to that as leukocytosis. If they have a white blood cell count that is below 4,000, you refer to that as leukopenia. And if you get this elevation in the white blood cell count, you may actually consider this as a risk for cardiovascular disease incidence and cardiovascular disease mortality. Then on its own, actually, WBC is not really a good indicator unless if you marry it with your differential count. Okay, you may know that an increase in the white blood cell count could signify an infection, but you're not really sure what kind of infection this may be. Is it a viral infection? Is it a bacterial infection? That's where your differential count comes into play, where you're able to tell whether each of these differential counts are going to be increased or decreased. These may lead to various other causes, which I will mention towards the end of this lecture. And the mistake that most healthcare workers and the mistake that most medical students usually make when interpreting a hemogram is that they usually only take a few of the parameters instead of looking at all the parameters and considering the hemogram as a whole. Like, for example, the parameters that people go for are the HB, the RBC, the WBC, the platelet, and of course the MCV and MCHC. But there are other ratios and other indices that are present in the hemogram that are going to be pointing you towards certain diagnosis and may actually give you the diagnosis before you actually carry out any other tests to confirm. So some causes of leukocytosis include things like bacterial or viral infections, autoimmune disease such as lupus, sorry about that, inflammatory disease such as rheumatoid arthritis. You may have some cancers such as leukemias, Hodgkin's disease. You may have allergic reactions. You may have tissue damage, which of course is going to be associated with inflammation. You may have burns, which is also going to be associated with inflammation and injury, tissue damage. Then you have kidney failure and pregnancy. Some causes of leukopenia, which is a decrease in the white blood cell count, include immunosuppression, which could be caused by HIV and AIDS, which is common in our setting, malnutrition, chemotherapy, and radiotherapy. You may also have some tumors such as lymphomas, diseases of the liver and the spleen. You may also have splenomegaly. You may have certain effects of certain antibiotics that may actually cause suppression of the bone marrow, and of course alcohol abuse. Moving on to the RBC and the hemoglobin level, remember that hemoglobin is actually a protein that's going to be present in the cytoplasm of the red blood cells. And this protein is going to be consisting of a protoporphyrin ring with iron, so you refer to that as heme, and a globin chain. They are pretty much 4 globin chains in adult hemoglobin, 2 alpha chains and 2 beta chains. Then this hemoglobin is going to be binding to oxygen and carrying oxygen towards the tissue, so it has a very important role in tissue perfusion, and it is the most commonly used marker to point towards anemia. And on the other hand, the red blood cell count is going to be reflecting the number of circulating red blood cells. So this is actually a very useful indicator of erythrocytosis, which is just simply a normal red blood cell count with an elevated hemoglobin. You can also use the RBC count to determine polycythemia, which is pretty much elevated RBCs, and you have absolute erythrocytosis. Then dehydration can also be used where the hematocrit is going to be raised and you're going to be having relative erythrocytosis. And then a decrease in RBC or hemoglobin is going to be indicative of anemia, and we can use the other indices such as the mean corpuscular hemoglobin and the mean corpuscular volume, as well as the mean corpuscular hemoglobin concentration, to actually pinpoint the etiology of the anemia. So we are going to go into details of this very shortly, but of course there will be separate lectures of anemia on this YouTube channel to actually go into much more details than I will in this review lecture video. Then some normal values of RBC. In men, you have 4.5 to 6.5 million cells per microliter of blood. In women, you have 3.8 to 5.8 million cells per microliter. So if you have less than 4.5 in males, less than 3.8 in females, then you refer to that as anemia. Then hemoglobin varies according to age. It also varies according to gender, but generally in men, you are going to have a hemoglobin of from 13 to 18. In women, you have a hemoglobin level of 11.5 to 16.5 grams per deciliter. Then hematocrit or packed cell volume. Remember that this is going to be pretty much the same thing. PCV or hematocrit, you're talking about the same thing. It's going to be the measurement that's going to be dependent on the number as well as the size of the red blood cells. And normally in males, you're going to be having a hematocrit of 40.7% to 50.3%. And then in females, 36.1% to 44.3%. Should you know these values? Yes, you should, because sometimes on your exams, they may not give you these reference values. Sometimes the lab, when they print it out, they may not give you these reference values. So you should have a rough idea of the normal range. Then for children that are below the age of 18, so those that are 17 years and below, the normal range actually varies by age. It also varies by gender. And these variations in the PCV can be seen in different circumstances and different scenarios. For example, in patients that are living at a high altitude, because there is hypoxia. When you go higher, so there's going to be release of erythropoietin, synthesis of more red blood cells. So it means that the PCV or the packed cell volume is going to increase. Pregnancy, also because of the hemodilution that may be there, may lead to changes in the PCV and or the hematocrit, significant hemorrhage, recent blood transfusions, even severe dehydration. With dehydration, you may actually see an increase in the HB, you may see an increase in the hematocrit. So you may have conditions that present to you with low hematocrit, so conditions such as anemia. You may have associated long-term illnesses, you may have infections or white blood cell disorders such as leukemias or lymphomas. You may have vitamin or mineral deficiencies. You may have recent or long-term hemorrhage. Then you may also have some conditions that are associated with a high hematocrit, so dehydration, because you lose a lot of water and it's like the blood is concentrated. You may have polycythemia vera, which is a myeloproliferative disorder that's going to be associated with excessive production of red blood cells. You may also have some lung and heart diseases, administration of testosterone supplement therapy. You may have dengue fever. And if you get a high hematocrit in a patient with dengue fever, this is actually a dangerous sign and actually that at risk of developing what is known as dengue shock syndrome. You may also have chronic obstructive pulmonary disorders and other pulmonary conditions that are leading to hypoxia. Reason being, if there is hypoxia, there is erythropoietin that's going to be released. Erythropoietin will result in stimulation of synthesis of red blood cells, increase the red blood cell mass, increase the hematocrit. So even doping or exogenous administration of erythropoietin, especially among athletes, if you want to actually perform better, those that run marathons, they used to dope using these chemicals that are going to be stimulating the synthesis of red blood cells to increase the red blood cell mass. If they have more red blood cells, it means that they can carry more oxygen and they would stay much longer. They would have more energy in participating in their sport. That's a good thing, but the risk of this is that their blood may become thick and they may actually start forming these clots. You may also have use of anabolic androgenic steroids as well as capillary leak syndrome that may lead to a high hematocrit. Moving on to the next red blood cell index, which is mean cell volume. This is just simply the average size of the red blood cells. So remember that the average size is also going to include the reticulocytes. Reticulocytes are these immature red blood cells that are released from the bone marrow. About 1 or 2 days after they are released, they're going to mature into red blood cells. Remember that these reticulocytes are much larger than the red blood cells. So if there is increase in production of these reticulocytes, what we're going to be noticing is that sometimes there may be an increase in the MCV. So a low MCV indicates that they're going to be small cells. Small red blood cells, we refer to that as microcytosis. A high MCV is going to be indicative that they are large cells, so we refer to that as macrocytosis. And MCV is going to be indicative or indicated in the evaluation and classification of anemia. And how exactly do we calculate this MCV? We say the PCV, or the hematocrit, multiplied by 10 divided by the red blood cell number. Then the normal MCV is about 80 to 96 femtoliters per cell, or for easy remembering, I usually tell my students that it's going to be 80 to 100. So if the cells are less than 80, you refer to those as microcytes. If the cells are less than 80, are between 80 to 96, you refer to those as normocytes. If the cells are greater than 96, you refer to that as macrocytes. So you may have some conditions that may present to you with a low MCV. So these are conditions such as iron deficiency, which has many causes. Conditions such as thalassemias, which also has many subtypes. You have anemia of chronic disease, sideroblastic anemia, lead poisoning, HBC, and other hemoglobin hybrids. You may also have spherocytosis, where the red blood cells are spherical in shape. Now, the key thing to remember here is for microcytosis to happen, you think that there is a problem that is affecting hemoglobin. Remember the structures of hemoglobin that are present. Hemoglobin is made up of heme. So the heme is going to be having the iron. It's also going to be having a protoporphyrin. Now, you could have problems in the synthesis of the protoporphyrin ring. You refer to that as sideroblastic anemia, where you have deficiencies in the two enzymes that are important, aminolevulinic acid synthetase and aminolevulinic acid dehydrogenase. Then you may also have problems with iron. Maybe someone is not absorbing the iron from the gut, or they are losing the iron through maybe a chronic hemorrhage. You lead to iron deficiency anemia. And even in chronic diseases, especially in prolonged chronic diseases, in the late stages of chronic diseases, you may produce a chemical that's known as hepcidin. Hepcidin is going to sequester iron, so it may lead to an iron deficiency that may be present. Then conditions that are going to present you with high MCV include things like vitamin B12, folic acid deficiency, liver disease, alcoholism, hypothyroidism, some hemolytic anemias, cold agglutinin disease, myelodysplastic syndromes, and pre-leukemias. You may also have aplastic anemia, benign familial microcytosis, some chemotherapeutic drugs, chronic hypoxia. This is just low levels of oxygen in the blood that may be seen with COPDs and even carbon dioxide retention. You may also get high MCV in carbon monoxide poisoning. Then sometimes anemia may be associated with normal MCV, so you refer to these as normocytic anemias. So you could get this in kidney disease, where the kidney is not really producing erythropoietin, so there is decreased production of red blood cells. You could also have acute blood loss that is often due to hemorrhage, anemia of chronic disease, specifically in the early stages. Same thing with inflammation. Then you could have endocrine disorders. You also have some hemolytic anemias. So here's a table summarizing what I've been talking about. So on this column here, you have low MCV and low MCHC. So you refer to this as a microcytic hypochromic anemia. So that's often due to iron deficiency anemia. Then you can also have low MCV and a normal MCHC. You may get that in thalassemias. That's a problem with synthesis of the globin chain. It may be alpha thalassemias or beta thalassemias. Then sometimes you may also have a low MCHC in thalassemias. Then you may sometimes have a normal MCV and a normal MCHC, so you refer to that as anemia of chronic disease. You may have a high MCV and a normal MCHC. That's often seen in vitamin B12 deficiency as well as folate deficiency. So those are just some important things to watch out for, which we will go in a lot more details when we look at anemia as a topic on its own. So moving on to MCHC, remember that this is an average concentration of hemoglobin in a given volume of red blood cells. It is going to be the ratio of the HB to the hematocrit, and it's going to be measuring how much hemoglobin is going to be packed into a cell. And we can actually use the MCHC in conjunction with the MCV and RDW, but remember that the MCHC is by far the single most important index that's going to be used in the diagnosis of anemia. We can actually calculate it in two ways. You can say the hemoglobin divided by the hematocrit multiplied by 10. The answer would be, of course, in grams per liter. You may also find it by dividing the MCH over the MCV, and the normal MCHC is 32 to 36 grams per deciliter. So if you have a value that's less than this, you refer to the cells as hypochromic. So it's going to be meaning that they're going to be having lower concentrations of HB in a given volume of red blood cells. So there is a reduced oxygen carrying capacity. Then you may get a normal MCHC, so you refer to that as a normal chromic type, which is 32 to 36. Sometimes you may get a high MCHC, which is hyperchromic, which doesn't necessarily mean that you have more HB than usual, because you can't accumulate more hemoglobin molecules in the red blood cells. So this just means that you have a normal oxygen carrying capacity. So you may have some conditions that are associated, anemia that is going to be associated with normal MCHC, anemia that's going to be associated with a low MCHC, and causes of high MCHC. So here are some of causes that are going to be associated with normal MCHC. So you can have blood loss, you can have anemia due to chronic diseases, mixed anemias, bone marrow failure, hemolytic anemias, many types. And then you may also have anemias that are going to be associated with low MCHC, things like iron deficiency, which may be with or without anemia. You may have lead poisoning, thalassemias, beta thalassemias, alpha thalassemias, and thalassemia intermedia. Then you may also have sideroblastic anemia and anemia of chronic disease, especially in the late phases. Then some causes of an increase in MCHC include autoimmune hemolytic anemias, cold agglutinin type. So here it's going to be falsely raised. You may have smokers, you may have hereditary spherocytosis, severe burns, liver disease, hyperthyroidism, sickle cell disease, the homozygous type, and of course in hemoglobin C disease. Moving on to the mean corpuscular hemoglobin, this is just simply the average amount of HB in a person's red blood cells. So the normal is going to be 27 to 33 picograms per cell. So 1 picogram is going to be equal to 10 to the power minus 12 per liter. And how we calculate the MCH, we say the hemoglobin multiplied by 10 divided by the RBC. So the MCV is low in hypochromic anemia and in iron deficiency anemia. Then moving on to the red cell distribution width, that often tends to confuse a lot of students, that often tends to confuse a lot of people. So remember that the RDW is going to be a measure of the variation of the sizes. But here, let me just go to a black screen so that I can explain this very well. So suppose you were in a class and you were to take the heights of many individuals. So let's say on this y-axis here, you have, maybe let's say the height, let's say, okay, here, let's say you have the height, okay, on the x-axis, height, okay, of individuals here, height. Then here, we say the number on the y-axis, the number of individuals. So in your class, you'll find out that there's a few individuals that are extremely short, and there are going to be a few individuals that are extremely tall. But the majority of the individuals are going to be falling within the normal range or within the normal height. So once you plot this on a graph, you refer to this as your standard, your distribution curve. So now this normal distribution curve is going to be a variation of the different heights of the people that are present in your class. You have the individuals that are very short, which are few, obviously, and you have individuals that are very tall, which are few, but the majority of the individuals are going to be of the normal height. Now, suppose if we were to actually calculate the area that is under this graph, let's say we go up to 20%. We'll go up to 20% here. So this will be a demarcation of 20% of the people. So let's draw a line here. So this area under the graph, or the length that is between the area under this graph here, you refer to that as your distribution width. So you have that as your distribution width of your height. The same thing is happening with the red blood cells. You have the red blood cells that are extremely small, you have the red blood cells that are extremely large, and the majority of them are within normal range. So you have this standard deviation, or this distribution of the different sizes. So it means that if you get a lot of red blood cells that are very large, this graph is going to be spread much wider. If you have a lot of red blood cells that are, most of them are within the normal range, it may become narrow, and so forth and so on. So moving back to this, so the RDW is going to be a measure of the variation of the red blood cell size. So it shows you variation in different sizes of red blood cells. So refer to that as anisocytosis. And then the RDW can be reported statistically as two main values. So you may have what is known as a coefficient of variation, which is RDWCV. You may also have a standard deviation, which is RDWSD. So the RDWSD, which is going to be expressed in femtoliters, is actually going to be a measure of the width of the RBC size distribution histogram, and is measured by calculating the width at 20% height. So that area that I calculated, that length, that space that I calculated at 20%, I'll show you some images on the next slide. So this parameter is not going to be influenced by the RBC size, so it's not going to be influenced by the MCV. Whilst the RDWCV, which is going to be expressed as a percentage, is going to be calculated from the standard deviation and the mean corpuscular volume, where you say one standard deviation of the red blood cells divided by the mean corpuscular volume, you multiply that by 100. So the normal RDW standard deviation is 39 to 49 femtoliters. Then the normal RDW coefficient of variation is between 11 to 16%. So an increase in this RDW, if you have normal other parameters, should actually alert you to investigate this person further. It may alert you to actually carry out a peripheral smear. So here's what I was talking about. So here is your RDW standard deviation, where you are actually measuring this 20% height, and you're measuring this width. Then of course, or calculating this width, and then of course the standard RDW cell volume, or rather coefficient of variation, coefficient of variation is where you're using now one standard deviation divided by your mean corpuscular volume multiplied by 100. So some conditions that may be significant for an RDW: chronic liver disease, colorectal cancers, different types of anemias, iron deficiency anemia, kidney disease, sickle cell anemia, thalassemias, polycythemia vera, ischemic strokes, carotid artery atherosclerosis, even cerebral embolism. So here's a table showing you the different anemias that may variate with the MCV and the RDW. So you may sometimes have a microcytic anemia. So microcytic anemias with a normal RDW may point you towards thalassemias. Microcytic anemias with a high RDW may point you towards iron deficiency anemia. This should make sense because think of it like this: when the red blood cells are being synthesized, they undergo steps of division. So they start off as a very large cell, which eventually shrinks and becomes smaller and smaller and smaller. So the fact that you're releasing these immature reticulocytes that are larger than the usual red blood cells, so it will increase the size of the graft, so it will have a high RDW. So you may also see this in hemolytic anemias. Then with the normocytic anemias that have a normal RDW, things like acute blood loss anemia, anemia of chronic disease, spherocytosis, and then those that are causing a high RDW combined anemias, sickle cell anemia, sideroblastic anemia, chronic blood loss. Then with macrocytic anemias with a normal RDW include things like aplastic anemia, pre-leukemia, liver disease, and then those that are going to be causing a high RDW, vitamin B12 deficiency and folate deficiency, cold agglutinin disease. Then you may also have anemia with a normal RDW and anemia with high RDW, which is these causes that I have listed to you above. So take your time to actually learn these causes and actually find a logical way to think them through. Then moving on to the platelets. So remember that this is going to be a measure of the number of platelets. Normally they're about 150 to about 450. Some labs use a threshold of 500,000 cells per liter. Then platelets are going to be circulating fragments that are anuclear and are going to be derived from a cell that's known as a megakaryocyte. So remember that the platelet is very essential in formation of the platelet plug, which is often the first step of coagulation or clotting of blood. It helps also in maintaining the integrity of the vascular tree and also production of certain compounds or certain chemicals such as platelet factor 3, which is an essential component in the coagulation cascade. And remember that these platelets are going to be deployed towards areas where there is infections, there's going to be deployed towards areas where there is injury, and they're potentially going to modulate the inflammatory process by interacting with white blood cells and also by secreting cytokines, chemokines, and other inflammatory mediators. So if you get an increase in the platelet count, you refer to this as thrombocytosis. If you get a decrease in the platelet count, you refer to this as thrombocytopenia. And notice, if you have a decrease in the platelet count, a decrease in the white blood cell count, and a decrease in the red blood cell count, you refer to that as pancytopenia. So some common causes of thrombocytosis, they may be reactive and they may be due to myeloproliferative neoplasms and some other causes. So reactive causes of thrombocytosis include chronic infections, chronic inflammation, malignancy, hyposplenism, so post-splenectomy, iron deficiency, and acute blood loss. Some myeloproliferative neoplasms such as may cause essential thrombocytosis. You may also have polycythemia vera. Other causes may be associated with other myeloid neoplasms, or it may be congenital indeed. Some common causes of thrombocytopenia include aplastic anemia, babesiosis. You may have chemotherapy, dengue fever, drug-induced thrombocytopenic purpura, which is often due to heparin, familial thrombocytopenia, Gaucher's disease, HELP syndrome, which is hemolysis, elevated liver enzymes, low platelet syndrome, which is seen as a complication of preeclampsia and eclampsia in pregnancy, hemolytic uremic syndrome, idiopathic thrombocytopenic purpura, immune thrombocytopenic purpura. You have neonatal alloimmune associated conditions, Onyale, which is pretty much acquired immune thrombocytopenias, pregnancy-associated pseudothrombocytopenias, splenomegaly. You may also have thrombotic thrombocytopenic purpura, and transfusion-associated and Gilbert's syndrome. Moving on to the reticulocytes, we usually measure the percentage and the absolute values. Sometimes this may not typically be there on your usual hemogram or your usual FBC. So the reticulocytes are these immature red blood cells that are going to be produced by the bone marrow, like I told you, and they're going to be released in the peripheral blood, where they're going to mature into red blood cells about 1 or 2 days after their release. And an increase or decrease in this reticulocyte count can actually be an index to actually point us towards the erythropoietic function or failure following anemia or hemorrhage or bone marrow dysfunction. So remember that the reticulocyte count is going to be measuring the compensatory ability of the bone marrow to replenish the red cells in circulation. And how do we find this reticulocyte count? We say the percentage of the reticulocytes over the total red blood cells multiplied by 100. So in adults, you have 0.5 to 2.5%, and then in infants, it can be as high as 2 to 6%. You may get some variations in the reticulocyte count, so you may have conditions that are associated with a low reticulocyte count, such as iron deficiency anemia, nutritional deficiencies such as folate, vitamin B12, aplastic anemias, bone marrow failure, which is often due to the effect of drug toxicity, infections or cancers, kidney disease, liver cirrhosis, side effects of chemotherapy and radiotherapy, hypoproliferative disorders, and you may also have anemia being due to, conditions that are resulting in high reticulocyte count, such as anemia that is due to increased premature destruction, that's the hemolytic anemias. If individuals are living at high altitudes, you may have hemolytic disease of the fetus and the newborn. You may also have chronic blood loss. Then moving on to platelet distribution width. So this is going to be reflecting the variation in the size distribution of the platelets. So this is platelet anisocytosis. So the normal range is about 9.6 to about 15.3 femtoliters. So remember that the platelet distribution width is going to increase in inflammatory reactions. And this should make sense, because when platelets are activated, they are going to swell up. So if there is an inflammatory reaction and a clinical disease, this is going to lead to platelet activation, and this is going to increase the platelet distribution width. So the platelets are going to be much larger in size. And these inflammatory cytokines such as interleukin-6, granulocyte colony stimulating factor, and macrophage colony stimulating factor are going to be regulating megakaryocyte maturation, where the platelets come from, platelet production, as well as platelet size. And remember that the platelet distribution width can be caused or can be used in the diagnosis of immune thrombocytopenia, and some conditions such as diabetes mellitus, cancer, cardio and cerebrovascular, as well as respiratory disorders may increase the platelet distribution width. Moving on to the mean platelet volume, this is just simply the average size of the platelets. So the mean platelet volume is going to depend on the degree of stimulation of the megakaryocyte, dependent on the thrombopoietic stress. So the normal MPV is about 8.9 to 11.8 femtoliters. So you may sometimes get a high MPV with a low platelet count. We see this if the platelets are being destroyed, usually by antibodies that may be or an infection or even some toxins. Like for example, in idiopathic thrombocytopenic purpura, you have these antibodies that are destroying the platelets and without any underlying cause, or we do not really know what's causing this. Then you may sometimes get a high MPV and a high platelet count. This is obviously going to be seen in the bone marrow that's going to be producing many platelets, typically due to some genetic mutations or even cancers. Then you may sometimes get a normal platelet count with a high mean platelet volume. This is going to be suggestive of hyperthyroidism or chronic myelogenous leukemias. There are some factors that are going to be affecting platelet count and volume. So people who live at low altitudes, like below sea level, may have these higher than average platelet counts. Those that live at high altitudes may have a high mean platelet volume, which should be actually considered as a risk factor for a heart disease and even cerebrovascular vascular disease. Then smoking, high blood pressure, high glucose levels without a diagnosis of diabetes have all been associated with a high mean platelet volume, especially in men. Menstruation, oral contraceptive use have been associated with a high mean platelet volume in women. And of course, strenuous exercise has also been associated with an increase in platelet count if it's severe enough to cause tissue damage. Some variations in the MPV are shown in the table below. So you may have some conditions that are causing a high mean platelet volume, so increase in the platelet size, and you have some conditions that are decreasing the platelet size. Conditions that increase the platelet size include things like Bernard-Soulier syndrome or Bernard-Soulier disease, which is just giant platelet syndrome. You may have some bone marrow stimulating drugs such as erythropoietin and thrombopoietin, diabetes mellitus, genetic abnormalities in the platelets themselves, heart disease or artificial valves, hyperthyroidism, non-alcoholic liver disease, preeclampsia, which is also referred to as toxemia of pregnancy, and HELLP syndrome, respiratory diseases, even sepsis. Some conditions that may have low mean platelet volume include things like low platelet counts along with the low MPV, which is going to be pointing you towards bone marrow disorders that slow down or even decrease the production of platelets, such as aplastic anemia. You may also have a high platelet count with a low MPV, which is obviously going to signify infections, inflammation, or cancer. You may have a normal platelet count with a low MPV, which is very common with chronic kidney failure. Sometimes you may have low platelet counts along with a low MPV, which is going to be pointing you towards bone marrow disorders and decrease in production of platelets, conditions such as aplastic anemia. So conditions with low MPV and variable platelet counts include things like bone marrow failure, lupus, splenomegaly, which is enlargement of the spleen, which often causes platelets to be trapped in the spleen. You may also have medications that suppress platelet formation, such as chemotherapy, hypothyroidism, iron deficiency anemia, HIV and AIDS. Increased MPV is associated, among others, with hypertension. You may also have diabetes mellitus, renal failure, atrial fibrillation in the elderly, obese patients, as well as smokers. Then moving on to the platelet large cell ratio. So remember, this is the proportion of platelets that are greater than 12 femtoliters. So normally you should have less than 30% of the total platelet count that are greater than 12 femtoliters. So this platelet large cell ratio is going to be considered as an indicator for risk factor that's going to be associated with thromboembolic ischemic events. So remember that the platelet large cell ratio is inversely related to the platelet count and directly related to the platelet distribution width and the mean platelet volume. So large platelets are going to be usually relatively younger, and they're going to be containing more intracellular granules, and they have a greater thrombogenic potential. And of course, the platelet turnover plays a very significant role in the platelet size. Then inflammatory cytokines such as interleukin-3 and interleukin-6 are going to be playing a regulatory role in the platelet pool, as well as lead to the production of larger platelets that are more reactive. And then moving on to the next parameter on the FBC is the immature granulocytes. So these are predominantly white blood cells that are not fully developed at the time of their release from the bone marrow. So they include things like promyelocytes, myelocytes, and metamyelocytes. Most of these, as you notice, are precursors of neutrophils. So with the exceptions of neonates, as well as pregnant women, as well as women that are post-delivery, the presence of these immature granulocytes on the full blood count may signify early stages of infection, early stages of inflammation, tissue damage, even the presence of a hematological malignancy. Then the presence of these immature granulocytes in the blood, you refer to that as a left shift. Remember, this is one of the things that is seen in infections, and this is going to be reflecting the bone marrow's response to bacterial infections as well as sepsis in adults. So this immature granulocytes may actually be a predictor of severe acute pancreatitis, independence of a systemic inflammatory response syndrome. So here are the immature granulocytes. Here you have a promyelocyte. Here you have metamyelocytes. Here you have, myelocytes, and here you have metamyelocytes. And of course, these are red blood cells. Moving on to the differential count, which I think should be the last thing that we talk about in this review lecture video. I hope you have been following each of the parameters, noting down the normal values and the conditions in which the parameters can lead to elevation and depression. Remember, these should be married with your clinical features. If you get a decrease in an HB, you should obviously suspect that there may be features of anemia in this patient when you examine and when you take the history of this patient. So when you come to the differential count, there are about 5 types of white blood cells that are divided into 2 main groups. You have granulocytes, which have these visible granules in their cytoplasm. You can have neutrophils, which are not acidic or basic. They have a mixture of both, so they pretty much have neutral granules. Then eosinophils have these acidic-like granules. Basophils have these bluish granules. And then you have agranulocytes, which do not have granules in the cytoplasm that can be visualized. Things like monocytes that are eventually going to differentiate into macrophages, lymphocytes. Then changes in each type of cell is actually going to be significant for different things. So we'll begin with the neutrophils. I shall list them in order from the most abundant to least abundant. So most abundant, you have the neutrophils, followed by the lymphocytes, followed by the monocytes, followed by the eosinophils, followed by the basophils. So there's a mnemonic to help you remember the order of the abundance of these white blood cells. So never let monkeys eat bananas. Never for neutrophils. Let for lymphocytes, monkeys for monocytes, eat for eosinophils, and bananas for basophils. So never let monkeys eat bananas. That's a mnemonic. So neutrophils and neutropenia. So remember that the absolute neutrophil count is about 2 to 7.5 times 10 to the power of 9. So neutrophilia is described as an absolute value that's greater than 7.5. So neutrophilia is going to be common in patients with bacterial infections, and the most severe infections are going to be associated with marked neutrophilia, and often a degree of myeloid left shift is going to be indicated by immature myeloid cells in the peripheral blood with toxic neutrophil granules. Then remember that neutrophilia may also be seen in non-infective disorders, so it's going to be a common response to steroid therapy. It's going to be a common response to severe exercise. It's also going to be following surgeries or splenectomy, but it can also be occurring in systemic vasculitis, in the presence of tissue necrosis, burns, bacterial infections, steroid, post-surgery, extreme exercise, systemic vasculitis, carcinomas, and in response to certain tumors, cardiopulmonary diseases, smoking. Even isolated neutropenia can be seen in some connective tissue disorders, like, for example, rheumatoid arthritis and Sjogren's syndrome. Neutrophilia may also be as a result of drug therapy. Some drugs that may cause neutrophilia include clozine, azathioprine, carbimazole, and cytotoxic chemotherapy drugs. And patients actually need to be carefully and regularly monitored when they are treated with these agents, and it is commonly seen following viral infections with EBV virus. And you may also have physiological neutrophilia that occurs as a normal physiological process. So here are some of the conditions that are going to be associated with neutrophilia, and here are some conditions that are going to be associated with physiological neutrophilia. So conditions that are going to be associated with neutrophilia include some fungal infections, some parasitic infections such as Pneumocystis carini, which is now referred to as Pneumocystis jirovecii, acute and chronic bacterial infections such as pyogenic bacterial infections such as miliary TB, chronic myeloid leukemias, inflammation, tissue damage, in patients with sickle cell crises, acute hypoxia, metabolic and endocrine disorders such as diabetic ketoacidosis, acute renal failure, Cushing's syndrome, eclampsia and preeclampsia, some viral infections such as chickenpox, herpes simplex, infarction, burns, malignancies such as carcinomas, lymphomas, melanomas, and sarcomas, drugs, especially corticosteroids, and some myeloproliferative and leukemic disorders such as chronic myeloid leukemias, myeloproliferative disorders, and just to mention a few of them. Then you may also have some physiological causes of neutrophilia, such as neonates that are generally just born with a higher neutrophil count. Then you may also have women of childbearing age that have a higher neutrophil count than men. You may have pregnancy that causes a rise in the neutrophil count. You also have childbirth or labor that's associated with neutrophil. Vigorous exercise can actually double the neutrophil count, so the distribution of white cells within the circulation. So here is neutrophilia, these are neutrophils, and this is a patient that had chronic myelocytic leukemia. Moving on to neutropenia, this is defined as an absolute neutrophil count that's less than 1. So neutropenic patients are going to be much more susceptible to bacterial infections without any treatment, and we usually are supposed to be giving them broad spectrum antibiotics. And if they are neutropenic and they develop what is known as neutropenic sepsis, we are not treating them with broad spectrum antibiotics and they get this overwhelming bacterial infection, it may actually be life-threatening. And remember that neutropenia is going to be associated with certain things such as vitamin B12 deficiency, folate, aplastic anemia, tumors, effects of certain drugs, as well as metabolic disease. And you get a sudden onset of neutropenia that is often seen with this overwhelming bacterial infection, and this is a very poor prognostic factor. And if you have this significant persisting neutropenia, that is going to be requiring a second opinion from a hematologist, especially in patients that have other cytopenias in other lineages. So mild chronic neutropenia is not going to be associated with infection, not associated with infection are reasonably common, and you can actually refer to these as benign idiopathic neutropenia. Moving on to the lymphocytes, so the normal range is 1.5 to 4.5, so 20 to 40%. So lymphocytes are much higher and are more than the normal. Lymphocytosis is just pretty much a higher than the normal lymphocytes. Then if there's a persistent lymphocytosis with smear cells, it may be necessary for you to actually request for lymphocyte markers. So do your flow immunophenotype to rule out any lymphoproliferative disorders. So If there is atypical or even reactive lymphocytosis, it may actually be necessary to rule out some viral infections such as infectious mononucleosis, which is caused by Epstein-Barr virus. So some common causes of lymphocytosis include acute lymphocytic leukemias that may rapidly raise the lymphocyte count and the blasts that are present on the smear. You may have chronic lymphocytic leukemias, which may have lymphadenopathy and hepatosplenomegaly as other clinical features. You may have cytomegalovirus infections, some other viral infections such as hepatitis A, B, C, HIV and AIDS, as well as human T lymphotrophic virus 1, hypothyroidism, and pharyngitis. You may also have non-Hodgkin lymphoma. You may also have mononucleosis, syphilis, tuberculosis, and whooping cough, just to mention a few. Here is a picture showing lymphocytosis. So all these blue things are lymphocytes, and this is a picture of a patient that had chronic lymphocytic leukemia. So moving on to the monocytes, remember that the normal monocyte count is between 0.2 to 0.8. Monocytosis is an increase in the number of monocytes in the circulating blood. So this is obviously going to be a feature of chronic infection with tuberculosis and syphilis. It's going to be also as part of inflammatory reactions in Crohn's disease, even in ulcerative colitis, as well as certain carcinomas. So if you get a persistent monocytosis that is unexplained, particularly if there is associated anemia or thrombocytopenia, there may be a feature of myelodysplastic syndrome. There may be a myeloproliferative disorder, so a hematological assessment should be advised in those cases. Some conditions that are going to be presented to you with monocytosis include things like pregnancy, some infections such as tuberculosis, brucellosis, listeriosis, subacute bacterial endocarditis, syphilis, and other viral infections, and many protozoa and rickettsial infections such as Chalazar, malaria, Rocky Mountain spotted fever, blood and immune causes such as chronic neutropenia and myeloproliferative disorders, autoimmune diseases and vasculitis, SLE, rheumatoid arthritis, and inflammatory bowel disease, some malignancies such as Hodgkin's disease, and certain leukemias such as chronic myelomonocytic leukemias and monocytic leukemias. So here is monocytosis. So these are monocytes. This is a monocyte here. So this is chronic myelomonocytic leukemia. So moving on to eosinophils. So remember that eosinophilia is actually much less common finding in clinical practice, but the search for a likely cause is often rewarding. So normally the normal absolute eosinophil count is between 0 to 0.4. So mild eosinophilia is common in patients with asthma, hay fever, parasitic infections, allergic conditions, hypersensitivity reactions, aspergillosis, vasculitis, and eczema. You may have mild eosinophilia that is common in patients with asthma and hay fever and eczema, but rarely does the count exceed 1. Then a few cases remain unexplained where previously known as hypereosinophilic syndrome, but these patients are increasingly rare now that we have these molecular diagnostic mechanisms that are going to be able to characterize these as clonal eosinophilic leukemia. Some causes of eosinophilia include acute myelogenous leukemias, allergies, ascariasis, asthma, atopic dermatitis, cancer, Churg-Strauss syndrome, Crohn's disease, drug allergies, eosinophilic esophagitis, eosinophilic leukemia, hay fever, Hodgkin lymphoma, hypereosinophilic syndrome, idiopathic hypereosinophilic syndrome, which you're going to be having a high eosinophilic count of unknown origin. You may have lymphatic filariasis, which is a parasitic infection, ovarian cancers, parasitic infections, primary immunodeficiency, trichinosis, which is pretty much a roundworm infection, and in ulcerative colitis. So here's an example of eosinophils. And of course, this is a patient with eosinophilic leukemias. Moving on to the last white blood cell differential, which is the basophil. These are the least numerous of the myelogenous cells with the large blue granules. And the basophil is defined as, or the basophilia is defined as a count that is of 0 to 0.1. Then basophilia in the presence of numerous circulating blast cells is going to be suggestive of an acute myeloid leukemias. So you may get an elevation of basophils that may also be representative of multiple other underlying neoplasms such as polycythemia vera, myelofibrosis, thrombocythemia rather, and also in other rare cases such as solid tumors, allergic reactions, chronic inflammation that's going to be related to infections such as tuberculosis, influenza, inflammatory bowel disorders, or even inflammatory autoimmune disorders. You may also get chronic hemolytic anemia and infectious diseases such as smallpox also are going to be causing an elevation in the basophil count. Certain drugs and even food ingestion may also be correlated to an increase in the basophil count. Here's a rare picture of a basophil. So this right here is a basophil. Thank you for spending your time to listen to this review lecture video on the hemogram. I really hope it helps you understand each of the parameters that are present on the hemogram. And the next time that you look at a hemogram, you will know exactly what you're looking for, and you have a very substantial differential diagnosis about what your patient may be suffering from. If you haven't yet subscribed to the channel, please subscribe to the channel, drop a like, drop a comment, hit the bell notification icon to be receiving notifications of such videos as I post. Tell a friend to subscribe to the channel, to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time,